Hi, I'm Gordon Christensen, as you undoubtedly know, and we are going to now be doing a overall presentation on conservative treatment of the edentulous mandible. I think it's one of the most inopportune things that we have in the profession right at the moment. We're not treating the edentulous mandibles. There are 40 million people in the United States alone, out of 200 million people, who have an edentulous mandible, believe it or not. Now, let me tell you how you may get more information if you so desire to do so. This particular slide shows the group that puts the words in my mouth. Clinicians Report and Track Research, both nonprofit completely. We're the only product evaluation group in the world that evaluates products free of charge, with no manufacturer money, no government money. This group makes videos, and that group donates money to these two groups to make them go. There are two websites I'd like you to be aware of. PCCdental.com, and there's an enormous amount of information on there. If you go into PCCdental.com, click additional resources, you will find information on anything that we have done research on. And if you go to cliniciansreport.org, you will find the last 10 years of research in Clinicians Report. If you subscribe to Clinicians Report, you're into that free. If you don't, there's a minor charge to get into it. On completion of this presentation, you should be able to list 3 methods for conservative treatment of the edentulous mandible, differentiate and discuss 4 different categories of root form implants, 4 different categories. Some of you think there's 1. Discuss in detail 3 conservative and affordable techniques for treatment of the edentulous mandible. I get quite frustrated when I hear people talking about $100,000 cases, $300,000 cases. Average American is making $51,000 a year for a family, and we're talking $300,000? Give me a break. These people that have edentulous mandibles have virtually almost no money. We've got to get in there at a more affordable level. In my opinion, and you may disagree with me, the resorbed edentulous mandible is the singular most commonly occurring thing that you and I do that is quite debilitating. You think about it. Try to find something else that you see day to day that's more debilitating than a resorbed edentulous mandible. The maxilla is close, and a Kennedy class 4, which is obviously no anterior teeth, is close. And then you have the ones you hear about all the time, Kennedy 1, 2, and 3. And those can be restored in many different ways, as you know. Approximately 40 million people, as I said, in the United States alone have edentulous mandibles and maxillas. I think that's appalling in a country that's supposed to be a developed country. We're worse than many other countries. You look at the mandible on the left and you say, wow, that'd be easy to restore. Well, yeah, for a while, till that resorbs down. Frankly, this one is easier to restore than that one, because this one has cortical bone on the facial, cortical bone on the lingual. It's almost like rock to put implants into that. This one is pithy. If I'm going to do the now popular all-on-4, we would have to cut off about 4 millimeters of bone to even get white enough bone to put implants in there. On this one, there's no problem. You go right into it and you have the implants in place. What are the alternatives for conservative treatment of the edentulous mandible? Keep in mind, I'm talking conservative now. I'm not really talking radical. I'm not talking hundreds of thousands of dollars. I'm talking treatments that will be somewhere between $5,000 and $10,000 US dollars. Most of them are around $5,000. Number 1 is 2 conventional diameter implants in the canine areas followed by an overdenture. Or I'll expand that to 4 small diameter implants, the 1.8 to 2.9 in the anterior region followed by an overdenture. Or one jump up financially, 4 conventional small diameter implants, 2 in the anterior region and 2 in the posterior region followed by an overdenture. Going from an edentulous mouth to 2 implants or 4 small ones is a major cliff. I mean, it changes the life of people. Jumping up to number 3 changes it a little bit from 1 or 2, not much. And if we go all on 4, there's a slight change. The big change is Edentulous to 1 or 2. And neither of those is very expensive. What are the bone types in the maxillofacial area? You know them probably as well as I. And Carl Misch was the one that put the original designation on these. D1, 2, 3, 4. And you probably know them well. I'd like D1, and that's the edentulous mandible, usually. Not always, if it's not resorbed. D2, what's that? That would be basically dense bone on the outside and porous on the insides. Anterior and posterior mandible, occasionally anterior maxilla. 3 is maxilla in the anterior area. And it's fairly soft, although I put implants in there quite often. I've been doing implants, by the way, for 35 years. We were one of the first ones in this state to even attempt to do so. And as a prosthodontist, that was quite an adventure because nobody wanted prosthodontists to do implants, even though implants, root form, you may not know this, did not start with surgeons. It started with general dentists and prosthodontists. You think about the names, I could name 10 off the top of my head. What's 4? 4 is the posterior area in the maxilla, and it is crummy bone. And we're not going to deal with it much in this presentation. Type 1 bone is the best. That's where we're going to be in this presentation. Type 1 bone. That would be restored bone in the anterior mandible. Type 3 maxilla could be good bone. We do many there for complete dentures. And the rest of these basically are worse. If you go up and down the line, and you can take the time to read that while I'm talking, I would like at least 2 implants in the edentulous mandible, canine. And ADA has now said that should be your primary treatment plan, believe it or not. Primary, not down the road somewhere. You make that as the first treatment plan. Patient denies it, fine. You tell them we can make a normal denture. However, when you come in and tell me that denture is not holding in well, guess what? We can then put some implants in and retrofit it to your current denture. I have some people who do that. On the other hand, most will buy the 2 implants. Now, I'll add that, change it to 4 small diameter implants, which I've now been doing 14 years with almost no failures. You'll see data on that later. Radiographs for implants, you tend to think you need sophisticated radiographs. I have been on cone beam now for 10 years. We have 2 currently in our 2 clinics. Both work well, and they show me things I've never seen before. But I have well over 20 years with no cone beam. So to say I have to have cone beam to do these implants is not correct. Yes, it adds a new dimension, but it's not mandatory. You need periapical radiographs if there are teeth left, and we're not really talking about that here. Panoramic you definitely need, regardless of what you're doing. Tomographic, some of you don't know what that means. That is essentially a facial lingual radiograph that shows the density of the bone, facial to lingual, and shows the amount of bone that's there. Cone beam is still the best, but you don't have to have that to do the kinds of treatment plans we're going to be talking about. If you're doing a lot of these things, you need cone beam right now. If you're not doing a lot of those things, I'll be candid, wait. You don't need it right now. Cone beam is great. I use it every single clinical day, but to say it's absolutely mandatory is foolish today. We've had decades without cone beam. I would not be without it personally, but for well over $100,000, you have to think about it seriously. Can you judge bone quantity from a 2-dimensional radiograph? The answer is no. You can only see bone from apical area to coronal area. You can't see what the thickness is from facial to lingual. Take a look at this as an example. You see the arrow over here? This is a 4mm ball placed just for an estimation. And you'll see there's about 4 millimeters there. Is that enough to place a standard diameter implant? Not unless I split the bone here. You go across this as the same patient, just different images, and you'll see About 4 millimeters there. Could I put a small diameter implant in it? You got it. I'll have a small diameter implant in that before you can blink your eyes. This can be extremely misleading. This patient looks like he has enough bone for 4 patients. However, when you actually slice that down the middle, you would find there was almost no bone from the coronal aspect to about where I have the cursor at the moment. Two-dimensional radiographs can be extremely misleading. Take a look at this one. Are we going to do an implant right there? It looks like there's plenty of bone from the crestal area to the floor of the nose. Let's flip that radiograph 90 degrees. And what do you see? The same radiograph. Let's flip it. Here's a 4 millimeter ball. Put it up there, and there's only 3 millimeters. What did it really tell me about that slide? It said, that's another bridge. That's not an implant. Unless you want to go into grafting, wait several months to a year, sprinkle owl feathers and ask the good Lord for help and hope the graft works and find a patient who has enough money to pay for the graft. That's a bridge. Well, how about this one? Take a look at how thin that bone is as it comes down like a ski jump. And look at this angulation. And even this one. This one could possibly take a very small conventional diameter implant, which would be 3 millimeters in diameter and up. No, these could be potentially small diameter implants unless you graft, obviously. As far as sensors are concerned today, they're all too thick, they're all too big, they're all too rigid, they're all too difficult to position, and someone's going to come out with one that actually shows initial caries. That's not the subject of this presentation, but it certainly is a high problem in the profession. I would have to say the most competitive ones at the moment would be the Dexys Platinum, the Schick 33, the Kodak is the old name, Carestream is the current name, and the Gendex one. But for some of you, a phosphor plate, there are 2 of them listed there, there are many. This is the most popular one, Air Techniques. A phosphor plate costs $40 or $50. These cost $10,000, $11,000, $12,000. You can get 100 images out of a phosphor plate and augment your CCD-CMOS and use the CCD-CMOS only for those things that demand an immediate image, such as implants, such as endo. And I've already said there are the potential uses for cone beam. See what you're doing. If you're doing complex prosthodontics, you're doing complex perio, endo, or implants, you need cone beam right now. Look at the cone beams that are out there. Most popular one at this particular point is the ICAT from Henry Schein. But there are many, many others. I have had Plan Mecca for 10 years, the Pro Max, excellent device. And as you look further from other distributors, Solon is about the second most popular one right now because, frankly, those who have the CEREC device can integrate with it very well. And Vatek is moving very rapidly with lower radiation, ability to change the size of the field, and so forth. There's so many of them out there. You take a look and see if these would help you in what you're doing. They would. I know they would, but you need to spend the time to figure out what fits your practice best. Now, for those of you who don't have $100,000 on the tip of your fingers, get a ridge caliper. How simple was that? A couple of $300? And that gadget will show you in millimeters the combination of bone and soft tissue. Now take a millimeter off the facial, a millimeter off the lingual. Let's say you've registered 6 here. That would mean there's 4 millimeters of bone. So simple to do something like that. That tells you quantity of bone, but not quality of bone. How about the size categories of implants? You may not think there are this many size categories. Let's discuss it for a moment. The one you know well would be conventional diameter, 3 millimeters to 6+ millimeters. I've seen them 7 millimeters. I've seen them 8 millimeters in some countries, with an average of about 12 millimeters length. That's what most of you are placing. That's what most of the surgeons dwell on. On the other hand, along came about 14 years ago, cleared through the FDA, a small diameter implant, 1.8 to 2.9, with an average of 13 millimeters in length. And then a lot of places there's not enough bone from crest to whatever, sinus or inferior canal, and that's where the wide body evolved. These would be short and fat, as you can see. What about this intermediate one? It's a relatively new introduction into the profession. 3 millimeters in diameter. Be careful, these are not very strong if they have a screw in them. I have some reservations on the intermediate diameters. If they're a single piece, abutment and screw, yeah, listen to them. But on the other hand, be very careful if there's a screw going down through there. They do break. Therefore, most of us would be doing conventional diameter. Let's stay right with the subject of this video. And that would be 2 conventional diameter implants, somewhere around 4+ millimeters in diameter, 11.5, 12 millimeters long in the canine areas. Or on a mandible, edentulous, it would be, if there's not enough bone facial be a small diameter implant, 4 of them. On a maxillary arch, 6 of them. Sometimes I put 4 in the maxillary arch. What is the difference between conventional designs and small diameter? If you can't see, there's something wrong with your eyeballs. The screw form of the small diameter implants, properly engineered, spreads the bone. All you do is screw it in and the bone spreads, facial and lingual. These do not spread the bone. You must find a minimal of about 6 millimeters. That's about a millimeter on the facial, millimeter on the lingual. You make the hole, screw the thing in. The bone's gone. Over here, you make the hole very, very slight, maybe a third to a half. Screw it in, and the bone spreads as you screw it in. You like that? Unbelievable. It's the most misused and inadequately used implant we have in the profession. They're the same surfaces as the standard diameter implants. There's no reason to question small diameter implants if they're placed adequately. Now let's go with 2 conventional diameter implants and an overdenture. Let's do that one first. Minimal bone necessary, and you may know this better than I, you may not know it at all. Your hygienist should know it, your assistant should know it, because they're talking to people. They can run a ridge caliper just as well as you can. When a hygienist has 30 minutes to 60 minutes just sitting there talking, let's talk about teeth. We don't need to talk about babies and flowers and cooking and so forth. Let's get on to teeth. Measure that bone, hygienist, from facial to lingual. If you've got 8 millimeters, including the soft tissue, facial and lingual, you have 6 millimeters of bone, and that could take easily 2 standard diameter implants. Let's say you have 3 or 4 millimeters diameter. What are you going to do? We'll look at that in just a minute. 10 millimeters in the crestal apical dimension, and almost all edentulous people have that. Most edentulous people do not have the first one, 6 millimeters facial lingual. And then there are the other things you would expect, a millimeter or 2 from inferior canal and or sinus. And then if you get close to the metal frame, and that's quite another challenge, and that would be preferably 5 millimeters, 7 millimeters. I've been right on the metal framing and not had problems. I've been 5 millimeters away and I've had paresthesias, so there's nothing sacred there. Your cone beam will guide you. Preliminary casts are highly critical for these things. Those were made by a dental assistant in alginate. They must know how to border mold. They can't just slop a big whop of the material in and go for it. They must have some form of border molding. And when they have done the border molding, wonderful. They get a cast that looks like that. And then a tray can be made, which we're going to do. And that tray would, with no reservation, allow us to make a denture that actually fits, which is an abnormality in the U.S., I will guarantee you. A tray made from Dentsply Triad tray material by either a lab or an experienced dental assistant, or even a hygienist. You look at how asymmetrical that tray is. That has 2 implants. You'll see in the tray the 2 indentations there and there. Now, what goes on top of those implants? I prefer in an edentulous mandible, when using only 2 of these, to have balls, spheres. Our stern goals just coming out with spheres that fit almost any implant major company. And you may get height of collar that varies. There are times when you want 2 or 3 millimeters. There are times when you want 1 millimeter. You want this part of the implant to stick out of the bone about 1 millimeter. So the gingiva, I said that wrong, out of the gingiva about 1 millimeter, so that the gingiva does not grow over it. Looking internally, you have obviously a rubber washer, if you will. And that rubber washer serves 6 months to 18 months. You pop it out, patient can put one in for $1. Not $100, not $500, $1. And of course it's screwed in, and we actually use a form of professional watt type. Treament makes an example of that will help seal that and retain it a little bit better. Your analogs are simple to use. They pop right into the impression. And you end up with something like this. This is something we just did recently. Now let's go back to the patient we're discussing. Here I have made a preliminary final impression. What is a preliminary final impression? It's obviously not the final impression. We've had a tray fitted to 1 millimeter from the nuchrobuccal fold all the way around. Dental assistants have made the tray, or dental hygienists, or dental laboratory technicians, whoever you prefer. And there are a few pressure spots, so dental assistants have relieved that, as you can see. This is Permadyne from 3M SB, heavy. And then there's the lower. The lower always has more pressure spots on it. By the way, don't relieve casts. You were taught in dental school to relieve casts. That's absolute stupidity. As you put the thing in and push it down into place, if you relieved it, what does it do? It finds the spots anyway. We've done hydraulics tests on that. Don't relieve it. You relieve the tray wherever there was pressure. And of course, you've got the 2 implants in that one. And then here's the secondary impression over that preliminary one. Now there's a little bit of pressure there and there. I think I adjusted that particular denture one time, post-op. I did not even adjust the lower, even though that looks like there's more pressure over there. The adjustment was not necessary. There are your 2 implants. This is the lighter weight material. It's subsequent, the blue, Permadyne, and the red is heavyweight. There was the other denture that someone had made. There's the impression of the one we're making. Don't allow your lab technicians to, in any way, shape, or form, polish the periphery of the denture. That's probably one of the most ridiculous things I see coming from most commercial labs. Of course, it looks shiny, but you've fitted that with delicate border molding, and you're now going to polish that all off? Forget it. A denture that you can't even pull out in the impression stage will literally fall out if the laboratory has polished the edges. Don't polish the edges. This is one of the more important things in this whole procedure. And you can read that while I'm talking. The dental assistant has made a final cast, poured it up, or technician, whoever you have do that. They've made a thin triad tray over the cast, trimmed the tray, placed adhesive in the tray, and then made an impression of the final cast. And then, of course, you put wax on that for your centric jaw relation. And there's the centric jaw relation. I've long ago given away Gothic arch tracings. They used the teeth themselves for the Gothic arch tracing at the seating time. Okay, now there is the denture back, but there is no rubber washer in there, is there? Nothing in there. So we'll try this in, adjust the internal of it, adjust the occlusion on the upper lower before we even think about putting the rubber in there, because it will distort it slightly, not much. And it will take 2 or 3 meals for that to settle into place. There's the new one, there's the old one. And let's get it finished. Now, how about taking a number 4 round burr, something about that size, and going inside of this housing and making 1 millimeter of relief? What's that going to do for you? That means every time the patient chews on this, that patient will have about 1 millimeter of shock absorber. I've done so many hundred of these, and I've yet to have a patient say, I don't like that. It's a significant and major jump from no teeth to 2 simple standard diameter implants. A major life-changing experience. In goes the rubber. A little water in the hole, place the rubber in, manipulate it slightly. I usually put 1 in at a time. I just did this morning. 4 in one given denture. Put 2 in at a time, and then another 2. The woman couldn't even get it out. And that takes a little while for her to learn how to get the denture out. And there she was, completed. Did she like this? There she is with her previous denture. She's had a stroke, so the one side pulls up slightly. And here she is with the new ones in place on the bottom. And she has sent in patient after patient because all of a sudden her dentures stay in and she can in fact eat. What did that cost her? Now, I know some of you are accustomed to extremely high fees. I think we're a health profession. I think we need to go fast enough, expediently, efficiently, to the point where we don't have to have exorbitant fees. This woman had 2 implants. Average American implant, according to ADA levels, is running around, at this particular time in history, about $2,000. So I have $4,000, let's say, in the implants. Typical denture today, done in a very adequate way, and done by a person who has had lots of auxiliary help, can easily be done with very significant profit for somewhere around $1,400 to $1,500. So that a denture on the lower for this woman would be somewhere around $5,000 or $5,500. Now put an upper denture in, you've got $7,000, give or take. Can she afford that? Almost every family can with proper education, no question. Let's look at technique 2. 4 small diameter implants and an overdenture. Some of you are questioning whether or not small diameter implants work. I'll show you some data toward the end of this session that we'll spend together. They have the same surfaces as standard diameter implants. They have had a bad reputation because many got in on that concept early before they were placing surfaces on them. Many use them as provisional implants. Many of them have been used as so-called TADs, T-A-D-S, in orthodontics. So they've had, and TADs are supposed to come out, but if you place a small diameter implant with proper surface etching and proper surface blasting, it's the same as the standard diameter implants. Give me a break. If that is really questionable to you, we'll go to the literature a little later. Now, what was this same slide only for standard diameter implants? I said, what, 6? What have I got here? Facial wrinkle. 3, 4. Wow. We have just included 75, well, I'll give you a break. 60 to 75% of the edentulous population are in this category. Unless you want to cut off 4 or 5 millimeters of coronal bone and go down to where it's wide enough and sacrifice that bone and have the challenges of an all-on-4, which I've done many, going back as far as 30 years. We were doing all-on-6 at that point. The rest of this slide is the same as we looked at for the standard diameter implant. So the only real difference is the 3 to 4 millimeters in the facial render dimension. This would be 1.8 to 2.9 millimeter diameter implants. Why do we need these small diameter implants? Well, let me summarize. Number 1, no bone, no interest in grafting. 2, no bone, no money. 3, no bone, sick. 4, good bone, but sick. And 5, many people don't want to have their bone carved off. They want a minimally invasive procedure. You get me going with a couple of competent dental assistants, we'll have 4 small diameter implants in 15 minutes. If that denture is adequate, maybe I made it and they wouldn't buy implants. If I've made the denture or someone's made it who knows what they're doing, and it fits well, it just doesn't stay in, give me about 30 minutes. I'll send that patient home and they will eat a piece of meat. I'm serious. Because we won't even make a flap on many of these. These are my 9 commandments. How do I know them? From my own success and failure primarily. Because the rubber hits the road in your own practice. I can read all the articles I want. I can have all the schoolboys do their studies, and I've been one, I'm not criticizing. And yet, I have to do what works for me, based on research. And that's what our group does. We're Master's Report. We have 50 full-time people doing research. Do I even trust our own research? Not always. Not until we verified it in the mouth. Okay, what? We need enough bone. You can read these as I pop them up. We need at least 4 millimeters. I can do it in 3. I'd like 13, okay. Quality, what about bone quality? Screwing the implant into the bone should require 30 Newton centimeters. How do you know that? You have a little torque guide, no problem. I'd like 40. If I have 40, I have no reservation. We're moving very well. 30 will do it. Anything below that, forget it. They're going to come out. Width of the implant as wide as the bone will allow. Obviously, wider is better. Length of the implant, 13 millimeters. If we average all the small diameter implant companies, we're going to come out about 13 millimeters average in length. Shorter the implant, the more questionable it is, whether it's standard diameter or small diameter. Bruxers, I don't have to tell you, bruxers and clenchers will eat anything you put in their mouth. I don't care what it is. They will eat anything you put in their mouth. No more than 2 millimeters of soft tissue. You've been into situations where you look in the mouth and say, oh, there's a lot of bone and gums there. And then they go, and it goes, like a flag. Cut it off. Here's the ridge. Take a V wedge out of it, suture it down. 2 millimeters max. They need to be reasonably parallel. I've done many more than the 15, and that works. But the further you get out of parallelism, the less possibility there is of success. You need about 4 millimeters separation, so you can put a housing on it. Done them closer, certainly done further apart, but about 4 millimeters. Can you load it immediately? Yes. I load them immediately if we've made no flap. Some of them I'll load immediately even if we've made a very conservative flap. Not one where you've laid the whole head open, just a little slit across the crest of the ridge, separate just a little bit, take a periodontal probe, go down the facial, go down the lingual, just to feel if there are indentations there. If there's questionable bone, late loading. But immediate loading is very possible with these small diameter implants. All of those have been in 10 to 12 years. There's only one there, let's say, denture, as you can see, complete denture. These are situations where, well, look at the one on the lower right. Put a standard diameter implant in that, will you? No way. They were 1.8s. There are lots of success stories. I could go on and on and on. Is there a simpler, easier, and potentially better way than conventional diameter implants? I don't have any reservation to tell you. Here's an 80-year-old woman we did many years ago now. One of the first ones we did. She had no bone back in the back. You can pretty well see the metal foramen was right on the crest of the ridge. I want you to see her when we started her, and then I want you to see her 8 years later. The gingiva is kind of grown up around there, slightly. I know we prolonged her life. She died about 10 years after we put those in. And it was a total change of life for her. going back, you can see the gingival tissues are proliferated. We're not even in the attached gingiva, which is another wide cell. It's nice to be there, but the gingiva readapts itself. We rebased her old denture. I did not make these dentures. They were her original dentures. And I find many of the people who go for this technique are people who have had dentures made that are not quite adequate, and yet they're okay, and you rebase them using their old dentures. So that reduces the fee even more. And that is her old denture that I have rebased, and it stays in. Going back, she had one complaint. The first day back, I said, well, how is it? Don't like it. What don't you like about it? Can't get the blankety-blank thing out. And so we had to show her husband, who was more spastic than she is, how to get the thing out. Now let's look at a cone beam of a patient, and this is a classic example. Look at the skeletal. This is a primeka. That's the nerve canal, for crying out loud. Look at it. So I've got a precious little bit of bone in the anterior there, and you'll see in the center view, which is the cone beam view of the area right, well, wherever I've got the red line, I don't see it on this image. And we're going to have to go, here's maxilla, here's the nose out that direction. We're going to go down at about 15 degrees from the facial plane. Now there's the panoramic of that woman. Is that misleading or not? Here's that area that you saw right on top of the bony crest. We're going to put implants in this area. These were copings I had placed on natural teeth 26 or 7 years before. They're still there. I had to repair them slightly, not much. They were the implants. Now you can see they're slightly non-parallel. And why is that? Can't I spell parallel? When you're screwing these things in, you only make a hole about a third of the way, maybe half. And so when you're screwing, if you happen to hit cortical bone on the facial or lingual, it'll deviate the implant. And therefore, they're never quite exactly on. They're always slightly off, but that's not a problem, what you see there. And here was that particular denture. Patient happy? Or are you kidding? By the way, what do you do with these copings? Let's put 5,000 parts per million Prevident gel into those every day as she gets up in the morning or whenever she puts the denture in. She's satisfied, exquisitely satisfied. Now, I'd like you to watch this for just a moment and watch me place 4 implants through the soft tissue. We have about 6 millimeters of denture base there. 4 is I'm about going to turn the sound off and I'll narrate it. We have 6 millimeters there. 4 would be adequate. That's an old denture. I did not make it. That is a denture someone else has made, and it's okay. It's not wonderful. There's a ridge caliper. Now we've done a cone beam on this, but the ridge caliper will give you some idea of what's there. I'd like you to, when you see the next image, look at the posterior and see how little bone there is there. The ridge caliper tells us we've got about 6. Take 2 millimeters off for soft tissue, you're down to 4. How do we determine those? From the radiograph, from the probing, and we're going to go sagittal plane. We'll go right down parallel to the sagittal plane as much as we can. And let's incline it lingual slightly, otherwise we'll have the implants right in the teeth. And that doesn't work out. You've got gray teeth. Look how little bone there is back in here. Almost none. Mental frame is somewhere in there, which we would determine from the radiograph. That's a vis-a-vis pin marking that. Running about 800 RPM with a very small drill. This is the 3M system. It's about a 1.1 millimeter diameter drill. We're going to go down about a third of the way, pumping up and down, up and down, up and down with a little lubrication, a little water lubrication on it. And my fingers are facial lingual. That's going to guide me as to whether or not I have a challenge with touching the cortical bone. By the way, this video is available to you. It's a full hour. V2360 shows this from start to finish, including cone beam, the follow-up, the dentures, the whole thing. Parallel to the sagittal plane, relatively well. No major problem there. And let's put the next one in. I'll just show you a few of these. I won't take the time to go all the way. Now that hole has been made. By the way, that's a 1.8 by 13 millimeter standard diameter old ball from 3MSB. We're going to probably take that in. The hole itself is only about that deep. So as you start to screw, the bone will start to widen. And now I've screwed it into the depth of the hole. So the rest of the way, I'm going to have to deviate to meet whatever parallelism I could get with the other three. And there it's inclined slightly lingually, as you can see. And this continues right across until we get the 4 of them in. I like to leave them only part way in because then I can parallel them. Do you need a guide to put these in? Not unless you're one eyeball out or one hand off. No. You all cut crown preps. You know how to parallel something. And I'm feeling facial-lingual again, as you can see. And that does allow you to have a reasonable idea of where you are. Now, I'm very slightly off parallelism, maybe 5 degrees. That's not going to be a problem. I can deviate that as we start to screw it in and bring it back this direction slightly. Neither of those is past where I cut the initial osteotomy hole. It's starting to get some resistance on it. We'll put in a couple more now. And then test the torque. Make sure we're okay. There's no question. My fingers tell me torque very well, but you will see a torque meter in a minute. Same thing, up and down, up and down, up and down, up and down. This woman was terrified. She thought I was going to kill her. In fact, when I was done, she said, "When are you going to start?" And I said, "I'm done. It's just minutes to do this." Okay, I've got 4 in just at the depth of the original holes. Now we've got to see what kind of stability do we have there. Let's look. And that requires the use of some form of a torque evaluating device. And most of the companies have that available for you. This is the 3M one. 3M is, by the way, about 60% of the mini market right at the moment. And that's going to tell me right where I have my finger what amount of torque there is there. If it's 30 to 40, I'm in hog heaven. If it's more, I've actually broken some of these off. So somewhere around that is great. I like 40. 40 is wonderful. This one is now, I'm going to stop this video. That one is now at the right height. Why is it the right height? You watch. We're going to put a housing on there, and that housing should sit right on the gingival tissues. Can you see that? That's right on the tissues. That's too high. That's way too high. That's too high. So they should be screwed down right to there. Now, can you see if I screwed all those 4 down, took her old denture, let's say the denture was good. It was not good. I had to rebase it, so I can't do it on this basement. Let's say the denture was okay. And you made little wells, 4 little wells in the denture, and you tested it by putting it in and see if you heard noises. You put some fit checker in to find out if you actually had enough space. Then you took some stern gold, that's one of the better pickup materials, stern gold material, in the well, 2 at a time, and put it down into place, have them bite down with light pressure. They're going home and they're going to eat that night. They will eat that night. How long does it take for an implant to integrate? Everybody has different data on that. Somewhere between 2 months and 11 months. How about with these things? We don't know. Nobody knows. Nobody wants to sacrifice their mandible to figure that out. But several months, let's say 4. But you have to check the literature yourself on that to see what you get. I'm going to turn that off. I hope you'll look seriously at this video if you desire. I've got videos on everything, literally. I've got me doing Nobel, me doing NEOS, me doing basic, me doing mini. So look at our website, pccdental.com, and you will pick up videos on virtually everything in dentistry. Well, it was her old denture, and we were able to salvage this woman fairly well. The guy had it all slanted down and was even able to correct that somewhat. She has sent in patient after patient after patient. These are example small diameter implant companies. The red ones are the most popular ones. In popularity right now, 3M is the highest, Interlock is second, and Stern Gold is third. Here's a real comer. Zest is moving very rapidly. Glidewell is moving rapidly. All these others claim to have minis. Some of them are truly good designs. Some aren't too good of a design. Pick out a really good design there. Would you like to start it and very rapidly, as with this one, spread it? No. Would you like to start it out and slowly spread it like that one? Or like this one? This is the kind we just put in there. It has to be a very slow spreading of the angulation. Ideal. That's the mini mark from Henry Schein. Look at that taper. Can you see you would cut the hole about to there, start screwing, spread. That's a locator on top of that one. Blue is a coming company. There are a lot of them moving. Zest has now got an angle coming out before too long on the head, which allows you to screw it in and make them all parallel. Wonderful. Glidewell has their own machining and everything else at the moment. Glidewell's moving. And Interlock is one of the most popular ones on the market and growing. They even have little abutments that can be put on there. Blue, as I said, is moving quite rapidly. That was one of the original companies that then sold out. They've incorporated the concepts that are in the larger diameter implants, the horizontal lines, the excellent coatings, the platform switch, the entire thing. You can see pretty well what I'm saying up and down that line. Gary Nesnick from Implant Direct has created a kind of an intermediate size one. Now, there's nothing wrong with intermediate size if there's enough bone and if it's one piece, in my opinion. He has this Go Direct, which is 3 millimeters up here, but look at it down there. That's a 1 something. And so if there's, this has to be probably 5 millimeters facial angle to make this work, but that will work very well. And there's your Glidewell one again. Commercially available models. I hope you will get these. I don't care whether it's standard diameter or whether it is small diameter. They happen to be looking at a small diameter. You give that to the patient and tell them, you try to take this off. I can't get it off. Well, here, I'll hold it. Take it off. Put your fingernail under there. You know, the first thing comes out of their mouth. How much that cost? When can I get it? I don't care how poor they are. There are lots of good models out there. There's the 3M one with 6 on the upper. There's the Stern Gold one with 4 ERAs on it. Get some models. Put them in your hygiene room. There are 4 on the maxillary in type 3 bone. They have been in right now 12 years. 12 years. Was it worth it to that patient? Yeah. I made his denture before. He said, I can't eat an apple. Can you eat an apple now? Yeah. It's like any other human. There's that video I just showed you a little clip out of 2360. Takes the whole technique. Very important that the staff is upgraded on what implants are. And then in this case, it's mini. I certainly have them for the other kinds of implants as well. They need to know we need duplicates. We need a little cleaner technique for the normal operative dentistry or crown and bridge procedure. We need to have good infection control throughout. But that's what this goes through. It's almost mandatory for someone to see 2342 to know what to do with implants. Here's the third technique. Let's look at this one. This one is somewhat of a jump up from technique 1 and 2. Is it so far of a jump up that we're going to say it's exceedingly better? The answer is no. It's a jump up. The jump from no implants to 2 big ones or 4 little ones is a huge jump. this jump might be 10 or 20% more. But to some people, it's very desirable. Let's look. Here's a 35-year-old patient in need of maxillary immediate mandibular implants supported complete. Why do you think he's got all that hair all over? He's conscious about his miserable appearance. And it is miserable. And if you don't see patients like that, you're not a real dentist. You're a play dentist in a boutique practice. We see these all the time. Yes, he's got to lose some teeth. Let's just pop through here. We're going to take those teeth out. And here is the technique. And this is the technique for this patient. Obviously, it will be different for everybody. Exam, final impressions. The initial impressions, number one, were made by staff. Centric jaw relation, try in the lower trial denture. Remove the maxillary teeth, place implants in the lower, seat the immediate upper in the lower denture with provisional soft liner in the wells. I had to have a healing period. I had to lay a flap of probably 3 inches. You'll see it in a minute. The bone was irregular. We had to trim bone. Healing period then, impressions for the upper reed base and seat the upper and lower. Okay, they're removed. The flap was a big flap, and we had high bone, low bone. We had to trim all here and there and everywhere. Custom tray. Only it's approximated 20% of dentists use a custom tray. As a prosthodontist, I challenge someone to make an adequate, or let's say excellent denture with a non-custom tray. You can make a custom tray and use half the impression material, half the cost, better accuracy, better predictability. They're triad trays. We're going to use, in this particular case, the Sterngold technique. That's a 3.25. We'd have to classify that as a standard diameter implant with a point. It's going to spread bone. Hallelujah. And here's their 2.2 millimeter, which goes in where there's less bone. And you can have a straight head or several angles of taper on the top. Sterngold. There were the 4 we put in this boy. And there you see them. We had, what did I have in this? Had 3 of the small ones and 1 large one. With a little bit off angulation, no problem. And there it was as we initially seated them. And then, of course, he had to heal. That's the bloody day right there. The Sterngold system was the grandfather of the locator system. You may not know that. Sterngold started the whole thing. And Locator took the market because of some very, very clever devices and good marketing. But it's the same kind of a thing. You just have different colors of inserts. Black is the initial one. Notice the hole here. What's the hole for? That's when I seat this thing over the implant, the excess Sterngold pickup material can flow out of the hole. If you don't do that, there's a good chance that you will raise the vertical dimension. And then there's a cement. If that head is off somewhat, you need to have the the abutment form at a different angle. And that, if you just scan that picture while I'm talking, you'll see that is cemented onto the coronal part of the implant if your angulation's off. I've done that so few times, I'd have to say that usually you can get it very close to adequacy. And then you pick them up, as I said before. That was initially. And there were the first layers. And to take it out, it's the same thing you've always done. Cut the internal and pop the thing out. Did that change this boy's life? Are you kidding? Look at his eyeballs on the left side. Well, we made him fat, too. He got fat cheeks now. Started to eat again. Started to smile again. Got remarried. These are life-changing things for a very minimal amount of money. What would that cost? You got 4 implants, and they're minis. Well, the 3 were minis on this and 1 standard. So you can pretty well figure out that's still well within the ballpark of what a person who's even got minimal income can afford. Are there some other uses for small diameter implants or conventional diameter implants? I'll use these fees, and if you're looking at this much past when I made this, the fees would be long. These are ADA numbers right now, so that's what I'm going to base this on. They don't happen to be my fees. I'm not much different, but these are the fees that are national at the moment. Would you like to wear that parcel? No. Let's put a small diameter or large diameter there. You've lost the eye bar. You've got stability. If it's a ball, you can replace it and tighten it for $1 or $2 per rubber washer. If it's an ERA or locator, it's a little more expensive, but still wonderful. And the fee is low. How about, oh, this is a terrible parcel. Would you like to wear that? I wouldn't like to wear that. You got big eye bars sticking up like a bit of fork on the canines. 2 implants there. There's always a triangle of bone. And where is that triangle of bone? It is right there. You may not know that. You try to find a situation. And it narrows down back here. There's no question there. But you try to find a clinical situation where the cortical bone has not collapsed and it's cortical, lock. Screw it, right there. You've done it. Is that going to be super expensive? No. Will they like you and that? Absolutely. It's minimal with minis. This one is pretty obvious. Same thing, only half the mouth. And again, you're rid of the eye bar. There is some flexibility on that when they bite up and down for a minimal amount of money. And the roll is the same. That's a ridiculous parcel. I just did one like it today. And we had to go back in there and place rest there. No eye bar. You got your implant. I am basically not doing many clasps anymore. Just about giving up clasps. Oh boy, this is one of the worst ones, isn't it? Do I even have to say that? I don't think so. Implant. You may use this to put a couple more in the subsequent time and they have more money and finally do a fixed bridge across there. Fortunately, this is only about 6% of parcel dentures are coming to class 4. But to put a parcel over that, this person now has no displayable clasp toward the anterior. You might have some in the posterior. And they can chew again. Ridiculous. Low budget. Probably the worst is this one. You know that. There's no bone on the upper. The lower tooth is extruded. If there's bone, 2 standard diameter is wonderful. But there's usually not enough bone there. If you can do that, it is fantastic. But generally speaking, you can't really do that, which does what for you? 1, 2, 3, 4. Almost always I can get 4 small diameters in there. We had a patient referred in recently, young woman, where a dentist had suggested 2 iliac crest grafts in a 17-year-old and a fixed prosthesis with lack of assurance of acceptability and a fee of some $300,000. Are we crazy? I think so. I think we're a health service. I think we need to look very seriously at helping people with a moderate amount of money with a minimal fee. We can do it. That's not expensive. Look at that. Will that change the life of that patient? Young lady. Don't do some of this stupid stuff. This came in our lab. Look at the mess. I don't know where these guys get these ideas. Crazy. This is what is giving small diameter implants a bad name. And look at this. This guy lost his license over this very case. Let's not go nuts with this kind of a concept. Well-placed small diameter implants are successful. How successful? You can take a look at this. There are references all over the internet. If you go to PubMed, or you go to Google Scholar, or Cochrane Symposia, you'll see all the way from 100% in short term clear on down low. Is there anything there I've got that's under 90%? No. Some of them will go 5 years, 10 years of these studies. You look them up. The evidence is there. Okay, now, you've been with me about an hour. Can you list 3 methods for conservative treatment of the edentulous mandible? I hope so. What did we have? 2 standards? We had 4 minis in the anterior, or we had 2 and 2 with locators, ERAs, or something else. Can you differentiate and discuss 4 different categories of root form implants? 4. What were they? Mini, intermediate, standard diameter, large diameter. Discuss in detail 3 conservative and affordable techniques for treatment of edentulous mandible. Well, you saw all 3. Let's see if you can do it for yourself. You may get more information on anything you want from me or us at pccdental.com, or if you so desire, call our 800 number, 800-223-6569. We keep about 100 videos active. We have many hands-on courses in Utah with mentors that I have coming from all over the world to help me teach. And you come out of those courses with something you can go home and use tomorrow. Our catalog is readily available to you, 1 million every year. These are our most popular videos at the time I'm making this particular video. Snoring and sleep apnea has gone crazy. I had a sleep technician work with me. I had Mike Vitola work with me, who's observed thousands of sleep appliances. The mini implant one is right up in the top. So is this one. How do you repair things? You never get any of that in dental school. Some of these have just gone crazy, like that one, Christensen's clinical failures and how to avoid them. The first version of that I made had 20 things I won't do. Do you know how many in this one? 90. This is making RPDs and interpartial dentures without clasps. We have these patient education videos. Let's say you have a patient who is thinking about small diameter implants. These are 9 minutes. It will give them alternatives for care, an explanation of each. It will give them informed consent, and they will sit up, I guarantee you, and say, okay, do it. It's almost that easy. We've got a few other little offerings for you. You can put those patient education videos on an iPad. And how does that work? Well, sit a couple of iPads around in your office with a chain on them. And all we got to do is pick the thing up, touch one of those babies, and up will come my grinning face, usually. I don't know what they've got on this one. But you punch one, and up I come, and I'll start talking about something just for a few minutes. Now, when you come back into that operatory, guess what? You're saying, I got a cracked tooth. Looks like I need a crown. You do need. What else? We have documents that are available to you. There are over 80 pages here. 1 page each on a technique. Did I put sutures in or didn't I? Did we graft it or didn't we? Did I give you an analgesic or didn't I? Did I give you an antibiotic or didn't I? They can't remember anything in the chair. That's what this is. 80 pages of that kind of stuff. Get it? And now we've got our courses in Utah. Our continuum mentorship. For a young dentist, it's half price up to 6 years out of school. Good luck finding anything close to this value. For a mature dentist, if you took every one of those courses, you would be standard of care. You look at the people, Suzuki, Cliff Letter, Carl Kramer, and myself. If you can't find something to do in Utah, you're already dead. Look at that. What a pleasure to share a few moments with you. I hope you got something out of this. I'm sure I'll see you somewhere in the future. We appreciate you being here.